All right, hello everyone, and welcome to today's webinar where we'll discuss frailty and cognitive impairment in kidney transplantation. As always, it's my pleasure to have you with us today. My name is Deanna Fenton, Program Manager here at the Alliance. And before we begin, I'd like to take some time just briefly reviewing a few housekeeping items and reminders. Now, upon logging into today's webinar, you may have noticed that your audio lines are muted. Please note that they will remain muted throughout the course of today's presentation. This will help us to ensure that we have the best audio quality for both of our presenters. So that said, we ask that you take note of the chat feature that's located in the bottom left-hand corner of your screen. This chat will be used to pose your questions to our speakers during the Q&A discussion. So if you have any questions that come up during the course of the webinar, please feel free to submit them at any time. Once the presentation has concluded, we'll go ahead and transition into our Q&A discussion, where our presenters will address as many of your questions as time allows. Now, as an added note, when accessing our webinars, we highly recommend using the Chrome browser to ensure an optimal visual and audio experience. If you're already using Chrome and experience any audio issues, we do recommend reconnecting to the webinar using the phone number that was provided in your confirmation email. Should you need any assistance, please feel free to contact a member from the Alliance team or send us a quick note in the chat box. Now, for anyone interested in our upcoming webinars, please note registration is currently open for both installments of our Brain Death Declaration series. The first installment will focus on clinical and ethical challenges in pediatric brain death declaration. You can join us for that on November 3rd at 2 p.m. Eastern. The following webinar will focus on brain death declaration from the physician's perspective. Be sure to tune in for that the following day on November 4th at 2 p.m. Eastern. As always, to get the latest information on our upcoming webinar offerings, please visit our website at organdonationalliance.org. Now, for those of you seeking continuing education credits, we are offering 1 Set C credit and 1 nursing contact hour for this webinar. As always, there is also a certificate of attendance that will be available for those of you who may be looking for CEs that are not offered. Everyone joining us today is eligible to claim either of these credits or certificates. Prior to receiving your certificate, you will be asked to complete a brief online evaluation that will allow you the opportunity to provide us with your valuable feedback. If you're listening in a group, please be sure to get the evaluation email from your group lead. As a friendly reminder to all, you'll have 30 calendar days to complete your evaluations and claim your credits. Now, with that said, I'd like to go ahead and begin today's program by introducing our moderator, Laura Hand-Peter, Transplant Program Manager and Clinic Manager at Nebraska Medicine. Laura, thank you so much for joining us today. At this point, I'll go ahead and turn it over to you to begin today's program.
Thanks, Deanna. I'm really excited to introduce our 2 speakers today for the webinar. They have a fantastic presentation lined up. First, Dr. Mara McAdams DeMarco is an Associate Professor and Director of Surgical and Outcomes Research at Johns Hopkins. Dr. McAdams DeMarco is an epidemiologist who is committed to improving the care of older patients with end-stage kidney disease. She is a leading expert on the epidemiology of aging with renal disease. Her work has contributed to measurement of frailty during transplant evaluation. Nadia Chu is an assistant professor also at Johns Hopkins. Dr. Chu is an epidemiologist and gerontologist focused on understanding the role of frailty and post-operative delirium on dementia risk to provide the foundation for public health interventions designed to prevent and delay cognitive decline among high-risk groups, particularly older adults with end-stage kidney disease.
Great. I'm happy to take over the presentation now. Thank you very much to the Alliance for this opportunity to talk about 2 measures of gerontology that we feel are so important to both the transplant process but also to the patient care of our older kidney transplant patients. Again, my name is Mara, and we'll be passing off this presentation to Dr. Chu in just a little bit. And we would like to just acknowledge the role of the NIH in funding our research that we'll be presenting some findings from today. So if we think about who should be an appropriate older candidate for kidney transplantation, there are no strong guidance to help us figure out which is the right patient that should undergo transplantation. The AST suggests that patients whose overall health and life situation suggests that transplantation would be beneficial should undergo kidney transplantation. But how do we measure overall health and life situation? And when do we measure it on that pathway to kidney transplantation? As everyone in this group is aware, the path to transplantation is often long with many stops for patients along the way. They must first be educated about transplantation, referred to a transplant center, then undergo an evaluation, which can often take quite some time. They must then be added to the deceased donor wait list or identify a live donor and undergo donor workup. In either case, they have to either accept an organ from a deceased donor or undergo live donor kidney transplantation. And after all that time, then they are at risk for post-kidney transplant outcomes. And so if we want to improve those outcomes after transplantation, what is it we need to know about a patient along that pathway to kidney transplantation? Well, many years ago, we had the idea that studying measures of physiologic aging from gerontology may be one way to help understand which older kidney transplant patients are at risk for adverse outcomes after transplantation and which would really benefit from undergoing a kidney transplant. And the two constructs that we are interested in studying are frailty and cognitive impairment. Now I'm going to start by talking about frailty, and as I mentioned, I'll be passing off this talk to Dr. Chu, and she'll be speaking about cognitive impairment. When we think about cognitive impairment and frailty in our population, we see that kidney transplant candidates and recipients have a very high burden of frailty, 71% in older kidney transplant candidates and 25.4% in kidney transplant recipients. And while it's higher in our older adult population, it's clearly present in those who are aged 18 to 64, indicated by the blue bars. We see similar results for cognitive impairment, which again, Dr. Chu will discuss in more detail. So why is it we want to study frailty? What is it about this term that's commonly used, often seen in the lay press or in works of literature? Why do we want to study it in kidney transplant recipients? Well, let's walk through this exercise, and hopefully this will help you understand the importance of studying frailty. Imagine two patients that you're seeing who are undergoing evaluation for transplantation at your center. One is a 42-year-old and one is a 68-year-old. Who do you think will have better outcomes after transplantation? I'll give you a second to think about that and see. It should come pretty quickly to you. What happens if I give you one more piece of information? What happens if I told you that that 42-year-old was in fact quite frail, while the 68-year-old actively plays with their grandkids, still goes out running, and really is measured as being non-frail? Would that change your outcomes then? Would that change who you picked to have better post-transplant outcomes? Most likely it did. So inherently, you know that there's something about frailty that gives us more information than a patient's age alone. In fact, if we look at the outcomes, we can see that both this younger frail patient and older non-frail patient were at similar risk of delayed graft function, but a younger frail patient was at an increased risk of staying in the hospital longer after transplantation, was at risk of early hospital readmission, and quite strikingly was at more than twice the risk of mortality than their older non-frail counterpart. And what this again reinforces is that frailty is a measure of physiologic reserve that gives us some piece of information about that patient beyond just their age. So frailty was a phenotype that was originally identified and validated at Johns Hopkins by Dr. Linda Fried, a geriatrician and gerontologist. We began studying frailty in patients with end-stage renal disease over 10 years ago. And we now have we have approximately 4,000 patients on our wait list in which we've measured frailty, and we have almost 1,300 recipients in whom we've measured frailty. And as this cohort has aged, we've been able to look at longer and longer term outcomes. One reason we really were interested in this phenotype of frailty was because it really captured a patient's physiologic reserve. How well are they going to bounce back in the face of a stressor? It's measured as a multi-component syndrome, which includes both the physical and self-reported components of decreased walk speed, of exhaustion, of decreased grip strength, low physical activity, and unexplained weight loss. These were originally identified in a cardiovascular health study, which is a community-dwelling older adult cohort, in which 7% of that population was frail. Again, you can imagine that our ESRD population, even at younger ages, have a much higher burden of frailty. How do we measure frailty then? Well, we measure the shrinking component by ascertaining unintentional weight loss of 10 pounds or more of dry weight in the past year. We ascertain weakness by determining a grip strength test using a hand dynamometer, and we account for both gender and BMI for that weakness component. For exhaustion, we measure it using 2 questions from the CESD depression scale, in which participants report their exhaustion. We then measure physical activity using a Minnesota Leisure Time Activity questionnaire to assess how many times they've been physically active in the past 2 weeks. And we directly measure walk speed by averaging the result of 3 trials of walking 15 feet at a normal pace. Now, there's 5 components that need to be measured, but we can do this within routine clinical care, and it takes less than 10 minutes to measure. We've been doing this for the past 10 years at the time of evaluation and at the time of admission for kidney transplantation. And after these measurements have been taken, if we see that 3 of these components are present, then we know that that patient is frail and likely to have adverse outcomes while waiting for transplantation and after transplantation. One of the reasons, as I alluded to earlier, for our interest in frailty as a construct to help with risk stratification in our population is that it has some overlap, but yet is still distinct from disability and comorbidity. So knowing a patient's frailty status isn't just knowing who has more comorbid conditions. In fact, we're really getting at the underlying construct of physiologic reserve. How well is this patient going to bounce back after a stressor? And this figure here shows that overlap between disability, comorbidity, and frailty from community-dwelling older adults. We too see similar overlap in these 3 constructs in our ESRD populations. Okay, let's get into the prevalence of frailty by age just a little bit further. As I showed before, frailty is much more common in older adults, but we see the highest burden is in patients who are undergoing hemodialysis. Among kidney transplant candidates, we see about 25% of those older adults have frailty, and fewer of the kidney transplant recipients at both the older and younger ages are frail. What is frailty then a risk factor for among kidney transplant candidates? Well, we can look at the research that we recently published to give you a sense of how these frail kidney transplant candidates do while waiting for transplantation. And this was work that was done by a surgical resident at Johns Hopkins, Dr. Christine Hagen, when she was completing her PhD with us. So we get to see each other in person, but I thought I'd at least put up a picture to acknowledge the hard work of the first author of this paper. So if we take patients and we measure their frailty status at the time of evaluation, independent of all the other factors that are being measured during evaluation, we see that patients who are frail and being evaluated for kidney transplantation are much less likely to be listed than those who are non-frail. So if we look at this figure, we see the percent of participants being listed from the time of evaluation. You can see that the percentage of frail kidney transplant candidates is much lower both in the early period and up to 18 to 24 months after evaluation. And these results held up even after accounting for all the differences between the frail and non-frail kidney transplant candidates. Now, just among those who are listed, what we found was that those who were frail at the time of evaluation were much more likely to experience waitlist mortality. Again, in this figure, we have a time since listing, and we can see that the curve and the risk of mortality is higher at all time periods for those who are frail. And again, accounting for all those differences, we see that frail kidney transplant candidates who are listed have a 1.7-fold increased risk of mortality than those who are non-frail. And finally, for those frail kidney transplant candidates who are listed, they're much less likely to be able to gain access to kidney transplantation, so that they have a decreased incidence of kidney transplantation after listing. And again, we see here that the frail kidney transplant candidates have a lower cumulative incidence of transplantation, such that their curve is below that of the non-frail patients. And again, this holds up after adjustment. So in summary, what we see from these 3 sets of figures is that frail kidney transplant candidates are much less likely to be listed. Then once they're listed, they're at an increased risk of waitlist mortality. And once they're on that wait list, they're much less likely to actually receive a transplant. But measuring frailty at the time of evaluation isn't enough. And this is work that was done by my colleague who will be presenting next, Dr. Chu. She was able to show something very important. Measuring frailty just at the time of evaluation is not enough to understand a patient's true vulnerability for post-transplant outcomes, because we see that frailty changes between evaluation and transplantation. So many patients have stable frailty status, but we have some who are getting sicker, potentially because they're spending more time on dialysis, and others who are doing better, potentially because they had some acute illness at the time of evaluation. And the key point from this paper was that transplant centers should not just measure frailty once and make decisions about a patient's access to transplantation or their post-transplant management, but should really think about measuring frailty multiple times to truly understand how that patient is doing. Are they stable or are they getting worse? Now moving on to our kidney transplant recipient group. If we measure frailty at the time of admission to the hospital for transplantation, we actually need to learn a lot about their future risk of adverse outcomes. So in our research, we found that frail kidney transplant recipients are much more likely to have a longer length of stay. They're more likely to have early hospital readmission. And I will take a little pause here to show this figure that I really love. This is a figure of the early hospital readmission rate by both recipient age and their frailty status. And if we focus here on these two bars, I think this is really telling about what frailty measures. The early hospital readmission rate in those who were aged less than 65 and frail was quite higher than those who were non-frail but older, such that they were age 65 and above. And in fact, the older and younger frail kidney transplant recipients had similar rates of early hospital readmission. So frailty, rather than age, is really capturing that risk for early hospital readmission in this population. Also, we found that patients who were frail were more likely to experience delayed graft function, to experience MMF intolerance, and for long-term mortality. So clearly, knowing a patient's frailty status at the time of transplantation gives us a window into their post-transplant outcomes. In fact, frailty has become such a hot topic in transplantation that the American Society of Transplantation convened a consensus conference on frailty in January of 2018. And the overall goal was to understand what we know about frailty in all solid organ transplantation and try to develop a common definition for frailty. This work was published in the American Journal of Transplantation, and the consensus really notes that frailty is an important construct, but we really need more research across all the different solid organ transplant patients to truly understand what frailty is measuring. We then did some work with the same group to understand what is being measured in transplant centers nationally. So we surveyed 133 programs with a 66% response rate, and this represented 77% of all adult kidney transplants and 79% of all kidney transplant candidates in the U.S. What we found from our survey was that most transplant centers were measuring frailty at the time of evaluation, but very few were measuring it at the time of admission for kidney transplantation. When we asked what they were measuring, we got quite a range of different measurements. So the first one, the most common, was the timed walk test. The other was next was body mass index. And in fact, we even see that the phenotype that I've been describing throughout this talk is kind of midway down this list. Interesting also to us was the idea that cognitive function measured by the Montreal Cognitive Assessment, or the MoCA, and other measures of cognitive function were quite often reported as being measures of frailty. And hopefully by the end of this talk, you'll see that these are very different constructs. So we know frailty is bad. We know that there's many different tools to measure frailty. But the big question remains, what do we do to improve frailty prior to transplantation? One suggestion we have is looking at prehabilitation to improve frailty before transplantation. We initially did a survey of physicians caring for both older and frail patients with end-stage renal disease. And overall, both they were supportive and patients were supportive of using prehabilitation to help prime patients for transplantation. We then went on to conduct a study of 21 kidney transplant candidates in which we administered prehabilitation within the 3 to 6 months prior to kidney transplantation. For our prehabilitation pilot study, we used a physical therapy center at the Johns Hopkins PM&R outpatient center. Each patient attended monthly in-depth assessments with a physical therapist and performed exercises at home. They also did weekly sessions with a physical therapist assistant, and overall, we had great participation in this study. Participants attended 8.5 sessions on average. We actually captured a very wide range of patient demographics in our pilot study. We had patients as old as 72, and 66.7% of our population was African American. And very interesting to us, we found that frailty was actually quite common even in a group of patients who were participating in a physical activity intervention study. We looked at the amount of physical activity that the patients were doing based on accelerometry and found that at 1 month it improved by 32%. The daily log count before was 413, it increased to 547, which is really a significant improvement in physical activity. And we saw this both on dialysis and non-dialysis days. To me, some of the most telling evidence, though, came directly from the patients. 100% of the participants said that they were very satisfied with the intervention, and they had better endurance, more energy, and I've listed the quotes here. I won't go through them in detail, but I will point out the last one that really is my favorite. One patient told us that they were really feeling empowered and feeling good, and that really was the key to this prehabilitation. As we know, frailty is a multi-component phenotype, and we were able to target multiple domains of the frailty phenotype. We were not just empowering them, we weren't just improving their strength and their physical activity, but we were also giving them the confidence and the feeling of empowerment before going into transplantation. So in summary, we know that this freed frailty phenotype is a physical measure of the patient's ability to withstand the stressor and bounce back after surgery. We know it's associated with adverse outcomes both pre and post-transplant, and it's an easy measure to be able to ascertain at the time of evaluation and transplantation. I hope I gave you some insight into one possible solution to prevent frailty, which is prehabilitation. Again, this is another feasible option for the right kidney transplant candidates to hopefully prevent them from becoming frail and really prime them for the surgical stressor. And finally, I wanted to think about how frailty can be used for recipient selection. So frailty is easy to incorporate into the referral process and can easily be performed at a transplant evaluation. And really, this is the goal of helping to improve recipient selection. It may help the team accept marginal candidates who are in fact quite robust. It may help them to decide against transplanting candidates who just wouldn't tolerate transplantation, and the clear, a better option would be remaining on dialysis. To me, where I think frailty should be used the most in clinical practice is to help identify that older adult who would do well with a transplant despite their age. Are they really going to be able to bounce back and be able to truly enjoy the benefits of having the restored kidney function? And finally, you could think about frailty as being a screener for candidates who may need prehabilitation or some physical therapy exercises to help improve their physiologic reserves and such that they'll be better prepared for transplantation. So I hope that you've gained some insight into frailty and how this is one of the gerontologic tools to help us understand which kidney transplant candidates are ideal for transplantation. With this, I'm going to pass the talk to my colleague, Dr. Chu.
Hello, everyone. Thank you for having me. Again, my name is Nadia. For the rest of the talk, I'll be talking about cognitive function among patients with kidney failure. And in order to do so, I dedicated the first half to talk about cognitive functioning generally, what it is and how to measure it, and then I'll put it into context in the field. So first, what is cognitive functioning? It is a collection of mental processes controlled by the brain. And you can think of these mental processes as general or specific to a particular ability. When we talk about global cognitive function, we are referring to the general mental processes as a whole. When we refer to domain-specific cognitive function, we refer to specific abilities. In the bottom right, we have 5 main domains of cognitive functioning. Attention relates to the ability to concentrate or focus and process things despite distractions. Memory refers to the ability to learn and recall new information. Memory alone can be broken down into visual or verbal, working or episodic memory. Language is another domain encompassing the ability of comprehension and or expression. Visuospatial ability refers to the comprehension and effective manipulation of nonverbal graphic or geographic information. And finally, executive function refers to the higher order abilities of decision making, problem solving, mental flexibility, and inhibition. Now, these domains are distinct, but they are related. However, the distinctions are very important and often lend insight into underlying mechanisms or etiologies, which I'll talk more about in a little bit. We measure global and domain-specific cognitive performance with a variety of neuropsychological tests. There are over 500 published cognitive tests characterizing cognitive functioning, each with their own pros and cons. These tests cover a range of difficulty. Some are easier than others. They encompass tasks like wordless learning tests, which can request a test taker to list anywhere between 2 and 20 words, and participants would undergo anywhere between 1 and 7 trials. Time tests are also very popular, like the trail making test and the digit symbol substitution test. Both can capture executive function, but also encompass other domains like attention. The digit symbol substitution also encompasses working memory. Tests based on counts are also very popular. For example, naming so many four-legged animals in 60 seconds. And drawing tests are also common, like the clock drawing test and the Rayos-Street complex figures, both measures of executive function, but they can also encompass visuospatial ability as well. So for measures of global cognitive function, the 2 most commonly used screening tools in clinical practice are the Modified Mini-Mental State Exam, or the 3MS, and the Montreal Cognitive Assessment, or MoCA. Both can be used to monitor cognitive change over time, but they were actually designed as screening tools for identifying global cognitive impairment. The 3MS has been around much longer. It takes about 15 minutes to complete. It's an update to the original Mini-Mental State Exam with more standardized administration, more refined scoring, and 4 additional items on long-term memory, abstract thinking, category fluency, and delayed recall. It covers multiple abilities or components, including psychomotor skills, memory, identification or association, orientation, and concentration or calculation. And the score ranges from 0 to 100, where lower scores represent worse cognitive function. By contrast, the MoCA has recently gained popularity for its ability to identify mild cognitive impairment in populations that are more higher functioning compared to the 3MS. But both have their advantages and disadvantages depending on the population you are trying to study. The MoCA takes about 10 minutes to complete and is freely available. You can see a picture of the test on the left, just a single page with a series of straightforward tasks covering multiple abilities. In the top left corner, for example, you can see an abridged version of the trail making test, which is, again, a test for executive function and processing speed. Participants are asked to connect the numbers and letters in alternating sequences as quickly as they can, and they're then timed to see how long it takes for them to complete that test. They're also asked then to copy a cube and draw a clock that depicts the time, 10 past 11. Both of those tests demonstrate visuospatial ability and executive functioning. And as you go through the test, you can see participants would have demonstrated multiple abilities such as attention, short-term memory, language, and orientation. So the MoCA is a 30-point test. And like the 3MS, lower scores represent lower cognitive functioning. It's been validated and it's widely used in clinical practice. Now, I mentioned 5 key cognitive domains, each distinct but related. And as I had said before, the distinctions matter because they can lend insight into underlying mechanisms that can lead to more severe forms of cognitive impairment or dementia, which is a state of severe chronic cognitive impairment that often develops over decades. The 2 domains that deteriorate with onset of the most common types of dementia are memory and executive function. Now, it's important for me to note that these types of dementia are distinct, but they can occur together as mixed type dementia. This is why we don't often test just one domain. The global standard is to undergo a comprehensive neuropsychiatric battery that thoroughly tests multiple domains to assess which domains are compromised. Now, deterioration in memory is often attributable to the onset of Alzheimer's disease, which is associated with a buildup of abnormal deposits of proteins called amyloid plaques and tau tangles, whereby healthy neurons stop functioning, lose connections with other neurons, and eventually die, causing atrophy in brain tissue, particularly in the hippocampal region. The auditory verbal learning test, or the AVLT, and the Hopkins Verbal Learning Test, or the HVLT, are among the most widely used tests. These are tests of word list memory with multiple trials. But it's important to note that while these are tests of memory and language, it is possible to squeeze more out of them. For example, memory and language would involve the sum of the words recalled. But assessing the first trial alone would be an indication of attention ability. If a participant recalls 7 words, this would be an indication of excellent attention, given that this is the first time they hear those words in the first trial. You could also get a little of executive function by examining the order of the words that are being recalled. So if you could see the list of the words on the left side of the test on the right side of the screen, the order in which they recall the words or the types of errors that are made are an indication of executive function. For example, participants may rearrange the words to recall them more easily, like in groups of food or instruments, etc. So just something interesting to think about. So we talked about memory. For executive function, deterioration in this domain is often attributable to the onset of vascular dementia, which is caused by conditions that damage blood vessels in the brain or interfere with proper blood flow and oxygen delivery in the brain. Some examples of tests for executive function include the trail-making test, the clock drawing test, the Stroop test, and the Wisconsin sorting test. On the left is an example of part of the Stroop test. For this test, participants are required to go through the whole table, naming the color of the ink instead of reading the word, which forces them to actively inhibit a process. This is just one aspect of executive function. It takes a great deal of attention, and it's quite challenging. I do challenge you all to do it on your own one day. Now, I mentioned several tests thus far as examples, but it is very important to consider the many challenges that go along with using any cognitive test. The first is that the specific tests used often vary in terms of sensitivity and specificity for identifying cognitive impairment in terms of what they measure, and regarding cognitive batteries, which involve several different components. They generate multiple scores that can be difficult to summarize and interpret. The second is that test performance is often highly influenced by demographic factors such as age, race, and ethnicity, and education. An ideal test would be invariant across all groups, so that any observed differences by group are not a function of the test itself, but their true mean differences. These tests can also be very lengthy and tedious, which ties into the last point that tests are appropriate for different people. For example, demented individuals may be given blocks and told to complete patterns, while cognitively healthy individuals may endure more complex verbal learning tests. We also can't forget those who are visually disabled, intubated, or hearing impaired. Again, some tests might be more appropriate depending on a population's capabilities and what they are able to endure. So that's my brief overview on cognitive function and some of the tests that are used. Now I'll go through an overview of what we know about cognitive function in patients with kidney failure. We know that cognitive impairment is common among patients with kidney failure. Now you'll find that the reported prevalence ranges anywhere between 10 and 80%, because it depends on, again, on the population being studied and the tests used to define it, as I mentioned before. This includes whether you are looking at patients that are initiating dialysis versus undergoing evaluation for KT versus at admission for KT. Also, we're dealing with a much wider range of individuals in terms of age, younger versus older patients, anywhere between 18 years and older. And also, again, depending on the test that's being used, whether we're using the 3MS or the MoCA that were being used. So I'll start from the beginning of the continuum of care for patients with kidney failure. This was a study conducted to compare prevalence of cognitive impairment among patients initiating hemodialysis versus their age-matched patients not undergoing hemodialysis. This graph compares the percentages of normal to mild cognitive impairment, shown by the white bars, moderate cognitive impairment, shown by the light gray bars, and severe cognitive impairment, shown by the dark gray bars by age and by group. You can see a trend by age here, but the prevalence appears common across all age groups age 55 years and older. And if you take a look at the white bars for the total column on the last set of stacked bar graphs to the right, you can see that about 31% of those on hemodialysis were classified as normal or with mild cognitive impairment, compared to 60% among those in the comparison group. Now, looking at severe cognitive impairment, indicated by the dark bars in the same group, we see that about 34% of those on hemodialysis had severe cognitive impairment. And that's compared to only about 12% among their comparison group not on hemodialysis. Now, looking at more severe forms of cognitive impairment, like dementia, we find that risk of diagnosed dementia is also high among patients initiating hemodialysis. And this risk also increases with age. Specifically, it's been shown that the 10-year risk of diagnosed dementia post-hemodialysis was 19% for those 66 to 70 years of age. And this risk rises to about 28% for those 76 years and older. To put this into perspective, the 10-year risk in older adults generally from the Framingham study was only about 1.5% to 7.5% for the same age groups. So those initiating hemodialysis exhibit an especially great vulnerability. If we zero in on the trajectories themselves, studies have found that those initiating dialysis do experience cognitive decline, but mainly in executive function. This particular study, using data from the chronic renal insufficiency cohort study, or the CRIC study, found no change in global cognitive function or in memory function, but they did find a significant decline in executive function. If you recall back when I talked about the domains, you may remember that a deterioration in executive function could suggest that the damage may be vascular in nature. And indeed, the pathogenesis of cognitive impairment associated with kidney failure is now thought to be related to cerebrovascular disease. These are just some of the potential mechanisms that have been proposed by which dialysis is thought to affect this complex pathogenesis of cognitive impairment, including intradialytic hypotension, disequilibrium, inflammation, oxidative stress, reduced cerebral blood flow, and reduced residual renal function. So thus far, we talked about patients initiating dialysis, but what about those who are evaluated for kidney transplantation, or even those who undergo kidney transplantation? We understand these populations to be a healthier subset of patients with kidney failure, and yet we find that global cognitive impairment and executive function impairment among both candidates and recipients is still quite common across all age groups 18 years and older. Notably, as you can see from the bar graph, the prevalence of impairment is higher among KT candidates compared to recipients, and the prevalence does increase with age. If we look at age continuously, we do find that prevalence increases linearly with age among KT candidates and starts increasing linearly with age among KT recipients at age 50 years and older. These are the results for global cognitive impairment. And the same is true for executive function impairment, as you can see here. The prevalence increases approximately linearly across the age spectrum for KT candidates from 18 years and older. For KT recipients, that prevalence starts increasing significantly starting at age 50. So based on these data, we would recommend screening patients for cognitive impairment at KT evaluation, regardless of their age. Now, what kind of impact can cognitive impairment have on patients? Is this yeah, that's right. This is listing. Now, what kind of impact can cognitive impairment have on patient outcomes? It has been shown that cognitive impairment is associated with reduced chance of listing for KT overall. Patients with cognitive impairment at time of evaluation for KT was about 25% less likely to be listed for KT compared to those who were not cognitively impaired. Interestingly, it has been shown that cognitive impairment is associated with increased mortality risk, but only among patients with diabetes. Without diabetes. So you can see the green and orange lines represent the difference in mortality risk among those with diabetes. And the lines are not all that different from each other. They're pretty close together. But if you compare the red and blue lines, which represent the patients without diabetes, you can see a major difference in the risk of mortality by cognitive impairment. And the same was true for rates of kidney transplantation. You can see here that overall, there was no association between cognitive impairment and KT rates. But then when we observe the association by diabetes status, we find that only among those without diabetes, cognitive impairment is associated with reduced rates of KT. This finding, along with mortality findings among those without diabetes, suggests that cognitive impairment may have different etiologies in patients with kidney failure with and without diabetes. It may also suggest that those with diabetes may already suffer from extensive cardiovascular disease burden, such that any further burden introduced with the addition of cognitive impairment does not improve risk stratification. Now, looking at the healthiest subset, here we're looking at patients who have undergone kidney transplantation, which means these patients have been screened to be free of dementia by the time of admission for KT. Yet still, we do find that KT recipients are at even greater risk of dementia post-KT compared to older adults at the same ages generally. And that risk increases with age. And this may seem at odds with what you've likely read about, that kidney transplantation is thought to improve cognitive function. And it's true. From what we understand, with restoration of kidney function, we do see some short-term increases in cognitive function. This graph shows the trajectories of global cognitive performance among kidney transplant recipients by frailty status. Within the first year, we do see all patients, regardless of age, race, sex, and even frailty status, experience cognitive improvements within the first year post-KT. However, we do see that some subgroups, namely frail recipients, are vulnerable in the long term, while those who are non-frail plateau and remain steady with regards to cognitive function in the long term, as indicated by that solid line. We see that frail recipients experience cognitive decline after the first year post-KT, as indicated by the dotted lines between 1 and 4 years post-KT. So in summary, despite the many tools we use to measure cognitive function, cognitive impairment is common among patients with kidney failure across all age groups and stages in the kidney failure care continuum. Cognitive impairment is associated with adverse outcomes on the wait list, like lower chance of listing, waitlist mortality, and rate of KT. While we see that cognitive function does improve in the short term across all KT recipients, we do see some disparities in the long term. For example, frail recipients are more vulnerable to long-term declines in cognitive function. And given these results collectively, we recommend that clinicians should screen for cognitive impairment at evaluation for KT, especially among patients without predisposing conditions or characteristics like diabetes or age, or older age, I should say. Now the question is, how can screening help? Well, if done earlier in the kidney failure care continuum, we may be able to prevent or perhaps even reverse cognitive decline. This is an ongoing question. There are current ongoing studies assessing interventions to improve cognitive functions in patients with kidney failure, such as through home-based exercise training, cognitive training, or combined interventions. These interventions are hypothesized to improve cognitive function through increased cerebral blood flow, brain volume, and motor function in the short term, to ultimately prevent long-term adverse outcomes like graft loss, dementia, and mortality. And below are a couple of citations if you're interested in reading more about those interventions. But these interventions have been implemented among older adults generally, and they do appear promising. And of course, if you have any questions about anything that we've presented today, here's our information again. We're happy to take any of your questions and hear your thoughts.
All right. Thank you, Nadia, and of course, Mara, for your presentation. We'll go ahead and transition into our Q&A discussion at this point. But I'd just like to go ahead and remind everyone that if you do have any questions for either presenter, please be sure to submit them using that chat feature. Again, that's going to be located on the bottom left-hand corner of your screen. And then additionally, during the Q&A session, I'll have this poll up. So for those of you who may be participating as a group, I would like to ask that you just complete this poll to let us know how many people are actually in your respective groups. That said, I'll go ahead and turn it back to Laura to facilitate the Q&A discussion. Thank you.
Thanks, Deanna, and thanks, Dr. McAdams and DeMarco and Dr. Chu for a great presentation. Looks like we do have a question that came in. Can you please review what constitutes frailty?
Sure. And can I just ask a follow-up? Would you like to know about the components or how they're measured? Go back to the slides of the way. I'm going to go take the slides back. Sorry. Am I allowed to advance the slides back?
Sure, go ahead.
Yeah. Thank you. Give 1 second. I'll pull back up the slide.
I'm checking to see if they responded.
I can go through both. It's okay.
Okay.
Just taking a second to get back there. Sorry. Okay. And here we are. I think this slide is probably the most helpful. Sorry, one more. Here we go. So the physical frailty phenotype, or the freed frailty phenotype, is comprised of 5 components. The first is shrinking. The next is weakness. The third is exhaustion. The fourth is low physical activity. And the fifth is slowed walk speed. So we measure shrinking by asking participants to report their weight in the past year, and And then we look at their current weight, and we see whether they've lost 10 pounds or more based on dry weight. The second is weakness, which is measured with a dynamometer, in which we obtain grip strength. And then we look at the grip strength, and we adjust for both gender and BMI, and there's certain thresholds that we use to say whether or not a person has a weakness or not. The third is exhaustion, which is just measured by 2 questions from the Centers for Epidemiologic Studies Depression Scale, and ask participants to self-report exhaustion. The next is low physical activity, in which we ask participants about their physical activity in the 2 weeks prior to the study. This one's quite interesting too because it's leisure time activities. Some of the responses are a little bit dated. It asks about kind of bowling and things that maybe are not as common now as when they were when this Minnesota Leisure Time Activities was developed. But it's a good questionnaire, particularly for this population, because it's really getting at these kind of leisure time activities. We're not asking participants how many miles they're running, but rather getting at things like gardening, walking, things that they may not be recognizing as physical activity, but would contribute to their overall physical activity levels. Now the fifth is a walk speed test where we're actually observing 3 trials of walking speed. We have them walk 15 feet at a normal pace, and we can actually do this right out in the hallway. So we actually put down tape and measure tape for 15 feet. We leave it there, and we ask participants and patients to start at one end and just walk to the other end of that 15 feet. We time it as they're walking, and we just have them walk 3 times over at a normal pace. It's really not burdensome to patients, unlike some of the treadmill tests that I think feel a little bit harder for them to do and to recover from. So that would be how I would measure it. If you're interested, there's a calculator online through Johns Hopkins where you can enter data, and it will come up with the thresholds for you, and it will calculate a frailty score for you.
Perfect. They did respond, thank you, very helpful and much appreciated. So,
glad to be.
Thank you for the explanation. All right. Another question. For risk stratification, how much better is frailty compared to other widely used or mandatory measures?
Yeah, so I think the first mandatory measure that comes to mind probably to everyone is the Karnofsky Performance Scale, which is really a tool that was developed for patients with cancer that was for a period mandated to be collected by transplant centers. I will give that little introduction, and I'm going to invite Dr. Chu to respond because she's done some seminal work now on understanding the difference between frailty and KPS.
I mean, I think you've kind of covered it, but it's been shown that physician-perceived measures like KPS may not add as much in terms of prediction for adverse outcomes compared to objectively measured or even self-reported measures by the patient, like the frailty phenotype that Mara has outlined today. This measure encompasses both objective and self-reported measures. So it's been kind of it's been shown to be quite to prove quite predictive of adverse outcomes in comparison to the Karnofsky Performance Score.
So to summarize that, the foot of the bed test may be good, but this is definitely getting you more information to help with the risk stratification. Great question.
Okay, perfect. Thank you. I think we have time for one more question. How can we obtain true function if cognitive measures are highly influenced by participant characteristics? In other words, how much of the lower function we are seeing is a result of lower education as opposed to lower cognitive function?
Yeah, that's a very interesting question, in that the cognitive measures, as I mentioned, they're highly influenced by these by these factors, by these demographic factors, your age, even your sex, and even your education level. The way it's been done among community-dwelling older adults is they create these kind of standardized measures based off of the distribution of the entire population. This hasn't actually been done yet for a kidney failure population with ages 18 years and older, and it still needs to be done to create kind of these standard cutoffs for the particular population. Yeah, so this is kind of an outstanding question that still needs to be answered.
Hopefully you'll invite us back in another few years when we've helped tackle that problem.
It sounds like a great idea. All right, last question. Do we need to measure frailty and cognitive function, or can we just use our own judgment or even have patients report whether they are frail or have cognitive impairment?
Do you want to start first, Nadia, or would you like me to jump in?
I'm fine to start, and then do you want to
Sure.
finish off? Okay. So we've actually we've looked at data from NHANES, and we've actually just we've been finding that self-reported measures, for example, for cognitive function, are not quite as I guess, predictive of adverse outcomes compared to objectively measured. And this was interesting because with cognitive function, we always imagine that, you know, your self-perception of your cognition may be more informative. But in fact, these objective measures do a lot more than what you think you feel or know about your own cognition. And we're hoping to publish these findings very soon. Mara, do you want to talk about frailty from the frailty aspect?
Yes, certainly. So much of the frailty phenotype that we study is based on this underlying inflammatory process that's happening in these patients. And asking patients, you know, do they feel weaker, do they feel slower, isn't really going to fully capture the underlying biology of the frailty that we're interested in studying. So it may be helpful to get a sense of that, but it definitely shouldn't replace the phenotype that we described earlier. The interesting piece about the phenotype, though, is that it allows for both patients to provide some insight into what's going on, as well as that direct measurement. So these are things that I think can be easily combined. If you see a patient that you think is doing poorly, understanding how frail or how cognitively impaired they are is going to be important. So by no means are these meant to replace any clinical judgment, but they really are helpful to give objective measures and, importantly, to allow for kind of equitable organ allocation by comparing people using similar tools.
Well, thank you very much for answering those questions. Those are really good questions, and I think added a lot more context to the presentation. And I think, Deanna, that's the end of our questions. If you want to take it back.
Sure. Thank you so much, Laura. I appreciate your assistance with moderating today's Q&A discussion, more importantly, for your assistance in helping us to coordinate today's presentation. So a huge thanks to you. And to Dr. McAdams, DeMarco, and Dr. Chu, we thank you for joining us today and sharing your time to provide us with such an informative presentation. We appreciate the insights that you shared, and to your point, we look forward to possibly having you join us again in the future to provide us with some of those relevant updates. So thank you to all three of you ladies for your time today. And then to our participants, as always, we thank you for joining us, and we hope you found today's discussion valuable. We hope you all enjoy the rest of your day, and once again, we thank you for joining us.